Dear distinguished guests and dear colleagues, welcome to our course. I would like to mention the importance of ultrasound in pelvic mesh surgery. How to decide for mesh surgery is not the topic, but I will mainly mention on how we can follow up the mesh and its complications. Maybe you should do more research on who needs mesh surgery and who doesn't need. So we have our young colleagues, they can do the study. It has been shown that MRI and X-ray is not very effective in visualizing the graft materials compared to ultrasound. Whom should be imaged? After the sling surgery or the mesh surgery, we can check if the surgery was done right, or if the mesh slides to another position than it's placed, or if the patient doesn't know exactly what kind of surgery was performed, we can diagnose it with ultrasound by following up the mesh and its position. And also we can do a biomechanical check, and after the patient strains or in the upright positions, you can check the position of the mesh easily and see the biophysics of the mesh. You all know that actually the mesh is placed mostly in the mid-urethral plane as a mid-urethral sling, and this is how it looks with perineal ultrasound. This is the mesh here, this is the urethra, this is the levator ani, and you see the angle of the mesh is easily seen. In order to compare, this is the TVT mesh, here the tape, here is the sagittal plane, here is the tape. This is the intravaginal sling, this is the urethra and bladder, here is the tape, and this is another spark. Here is the mesh in the sagittal plane below the urethra. You know that the mesh should be placed in the junction of anterior middle third and middle third of the urethra. You divide the urethra by 3, anterior 1/3, middle 1/3 and posterior 1/3, and the mesh should be placed in the junction of anterior and middle 1/3 of the urethra. So if you check the mesh, the place of the mesh, you can decide if it's placed properly or not. If you place it near to the bladder, you will have voiding dysfunctions. The patient may have urgency, de novo urgency, or she might have, if it's too tight and dislocating the urethra uprights, you might face with inability to void. And sometimes they can only void in half upright position, not in the lower, but not in the upper, but half upper position because of the mesh displacement. This is another sagittal view. Here is the mesh, you see. We also use transvaginal ultrasound for the mesh. With this ultrasound, here is the transvaginal ultrasound, you can keep it in the entrance of the vagina, or you can just do a vaginal ultrasound, and while pulling back, you can trace the urethra and the bladder to see if there is any problem in the mesh surgery. In case of recurrent stress urinary incontinence, you can check the mesh, what happened, what was wrong. You see, here is the mesh, here is the mesh, and it has a little bit shrinkage. There is a shrinkage of the mesh. Or you can check for the residual urine volume of the bladder after voiding and see if it's more than 100 milliliter or more. If the indication of the mesh is not right, for example, you are placing a mesh in case of a diabetic patient, or you are placing the mesh too tight in the mid-urethra, they might have incontinence, but it might be due to overflow incontinence. They don't feel their bladder filled, but they lose urine. And if you place your probe in the lower abdomen, or just with perineal or transvaginal ultrasound, you will see that the bladder is full. You can also verify it. And for follow-up, we also use to evaluate the response of the patient to the medication. For catheterization, we also check for this. In pelvic organ prolapse, we placed bigger meshes. Now we have lighter and better meshes, but at that time we have these meshes. You see the mesh here. It was supposed to be placed below the bladder, but it's somewhere in the mid-urethra and the bladder. It might be a total mesh. There were very big meshes acting both in the mid-urethral plane and also elevating the cystocyte, complete forearm meshes. But you see the back arms of the mesh was accumulated below the urethra. It's not below the bladder. Here is a successful anterior vaginal mesh placed. Here is the urethra, here is the mesh. It was placed completely from the mid-urethra to the below the bladder. Here is another one placed. Here is the mid-urethra. Here is the mesh, beginning from the mid-urethra up until the end of the bladder. You see it here. After the mesh surgery, if the patient have pyrexia or she has a malodorous leukorrhea, check for the mesh. You can even diagnose the erosion of the mesh with transvaginal or transperineal ultrasound. If you didn't do a cystography, or if you didn't do a cystoscopy, you can check with ultrasound. Fill the bladder and check with ultrasound. If you have passed from the bladder with the suprapubic ultrasound, you will easily diagnose the hyperechogenic focus. And if it's left in place, you will see calcification of these cases. I don't have here, but in one of our case, at the time of birth, we have seen the calcification of the proline sutures, which was passed from the bladder. So whenever you do an ultrasound, just check the bladder, okay? You might come up with bladder papillas, and even I remember that I have diagnosed 2 cases of bladder cancer, which were just came for incontinence. So just check the bladder carefully, the bladder wall and the bladder. This is the isolated posterior vaginal mesh repair. See, the mesh is below anterior. This is the vagina, this is the bladder, and the mesh is placed properly with a posterior intravaginal sling to the posterior compartment of the vagina. Here is a severe mesh shrinkage. You can see that there is a kind of erosion here under the mucosa. The mesh, there is the shrinkage of the mesh. This is a problem because this causes urgency in the patients. Also, with ultrasound you can check, if you do a hysterectomy during mesh surgery, you can check for vaginal cuff abscess, hematomas, and also hematomas between the mesh and the bladder. If you did a posterior mesh, you can see the hematomas behind the mesh. So ultrasound is a useful tool. All of us have one opportunity to use one ultrasound in our clinics. So use it and check for complications, and for follow-up. After a time you will notice that you have better idea of how to place your mesh to improve your technique and to overcome the complications. Thank you.